Primero quiero presentar al doctor Prem. Ante todo, quiero agradecerle el que haya aceptado esta invitación y voy a hacerles un pequeño resumen curricular del doctor Prem. El doctor Prem es profesor de oftalmología, neurología y neurocirugía. Es vicepresidente del Departamento de Oftalmología en la Universidad de Chicago. El doctor recibió su título con honores, su título de médico, y obtuvo su PhD de Baylor College en genética humana y molecular. El doctor ha tenido posiciones previas en el Instituto de Wilmer, en la Facultad de Medicina de Johns Hopkins, y también fue oficial activo del Ejército de Estados Unidos, donde surgió su interés en los efectos visuales eferentes de las lesiones cerebrales traumáticas. Además de ello, el doctor es fundador de la unidad del Instituto Marcus, del Instituto Marcus, donde él, para pacientes con lesión cerebral traumática y rehabilitación. También el doctor es cirujano activo en órbita y cráneo, con un interés específico en los tumores de base de cráneo y además de ello en cirugías de pequeña incisión. Es miembro, por supuesto, activo de la Sociedad Norteamericana de Neurooftalmología y es miembro fundador de la Sociedad Académica Norteamericana de Cirugía y Órbita. Su investigación actual está referida a encontrar los tratamientos más efectivos para pacientes con riesgo de enfermedad de oftalmopatía tiroidea progresiva, para mejorar los tratamientos en el síndrome de hipertensión endocraniana y en las terapias vestibulares y visuales para superar la disfunción visual y también para la rehabilitación con pacientes con trauma cerebral. El doctor Prem tiene 220 publicaciones, tanto en investigación, capítulos de libros, materiales educativos, y él se ha dedicado a la educación de varios países alrededor del mundo. Creo que es una persona con una gran cualidad humana, and I think one of your qualities, in addition to your great curriculum, is your sensitivity, doctor. Thank you for to be with us today.
All right, thank you. It's a real pleasure to be able to speak to everyone. Let me bring up my presentation and we will get started. So, start out here, go to, good. Okay, so I'd like to start with a case. Thank you again, Emily, for translating for those who may not understand English as well. That is going to work much better than my trying to speak in Spanish. So we'll start with the case of a 48-year-old woman who noticed the onset of double vision 3 days ago. It occurred while she was lying in bed watching television, and she denied any pain. She had no trauma. The vision in each eye was not blurred, and she had no other neurological symptoms. And this is a typical patient who comes to see the neuro-ophthalmologist. And of course, when I talk to my residents, I ask them, what is the most important question to ask in a patient with double vision? Is the first question you want to ask, is it side by side or up and down? You know, you do want to know if it's horizontal or vertical, and that's not really the most important thing that I want to know. Is it worse when they're looking straight ahead, or when they are looking to one or both sides? We're looking for comitance or incomitance. That may be important, but it's not the most important thing. Is it worse looking at distance, near, both? And again, that is important, but it's not the most important thing. And the most important thing that I'm always telling them when I am in the clinic with them is it still present when they close either eye? Because we get patients who are sent with monocular diplopia, and this is an important problem, but it's an ocular disease. And corneal problems may cause this. It may be caused by cataract, even if the cataract is diffusing the light or distorting the light. And a type of double vision that we may see are patients who have epiretinal membrane that may cause a monocular diplopia. It also causes a different kind of binocular diplopia that I won't talk about today, that has been referred to as the dragged fovea diplopia syndrome. And when we think of patients with monocular diplopia, our medical students always think of cerebral polyopia because it's one of those incredibly rare conditions in which patients will actually see double because of a CNS problem. But that is exceptionally unusual and not really the first thought that goes through my mind when I see a patient with monocular double vision. So I'm going to talk about nuclear, infranuclear, and systemic causes of double vision, and some of this will be aimed at trainees, some of it will be a little more advanced in terms of content, and please, if there are questions, I can't monitor the chat feature, but Emily, if you want to interject at any point, please let me know. I do always mention that there are 5 ocular motor disorders that as a physician we can't afford to miss. And it's not just because these result in malpractice suits, it's because missing this results in the patient having a bad outcome. We'll talk about some, but not all of these: aneurysmal third nerve palsy, giant cell arteritis, pituitary apoplexy, cavernous sinus thrombosis, and myasthenia gravis. Those of you who take care of patients with double vision know that double vision has a tremendous effect on visual quality of life. We did a small study years ago where we tried to look at a correlation between diplopia severity and reported quality of life instruments. And these are pictures of my orthoptist, Alex, who was one of the authors of that study, looking in different directions with a device on his head that measured where in space the head is positioned. And we mapped out where patients had their double vision and made a correlation between how symptomatic they were and how small or large their zone of single binocular vision, how large their zone of double vision might have been. And these shrunk, but they can show you that there's a linear relationship between the amount of diplopia that patients have and their decrement in their visual quality of life. So when you approach that patient who has double vision, remember, it's not just a matter of making a diagnosis in order to find out why they are seeing double. It's also ultimately going to be our responsibility to figure out how to treat these patients because they do get a severe distortion of their visual quality of life because of that diplopia. And that's both psychosocial, as shown in this top graph here, as well as truly functional in terms of their daily activities, like driving, like going to the store, like interacting with other people in more normal times where you're allowed to do that. So when I think about double vision, binocular double vision, I break it down into 3 categories. And this was taught to me many years ago, that we think about it as mechanical or muscular, neuromuscular, and neurological disorders. And so I will start with the mechanical or muscular disorders. And there are a number of different disorders that fall into this category. I'm going to spend a little bit of time talking about thyroid eye disease because it's a common cause of double vision. These patients often present to the ophthalmologist or the neurologist with their complaint of double vision, and they may not have a history of any kind of thyroid dysfunction. If they present with a painful mechanical diplopia, I'm going to be thinking more of orbital myositis, perhaps infiltrative processes such as lymphoma or sarcoid that may get into the extraocular muscles. I'll show some examples of trauma with muscle entrapment, and tumors also. If there are orbital tumors that are impinging on the globe or impinging on one of the extraocular muscles, that can lead to diplopia as well. And so when we see a characteristic patient who has double vision because of a mechanical problem, she may look like this, and in primary gaze, you see that there is a vertical misalignment of the eyes. There are also some changes of the eyelids that you can appreciate. And now when the patient is trying to look up, the right eye simply isn't going up. The left eye is not going up too well either, and there's not a whole lot of difference between what she's able to do when she tells you she's looking straight ahead and when she tells you that she is looking up. And so these individuals, when they present like this, they are going to be also presenting with perhaps a restriction or a limitation of horizontal movement of the eyes as well. So some of the characteristic features that we see in a patient like this who may have thyroid eye disease, we see that there is eyelid retraction. We see that when the patient looks to the right, we'd expect the right eye to be abducting much better than it does, but it is unable to do that. Similarly, when the patient looks into left gaze, they are unable to move the eye well into any kind of abduction, although the adducting eye moves perfectly well. So the combination of this pattern of eye movement abnormality, along with the typical eyelid changes as we see here, as well as some injection over the extraocular muscles, these are all characteristic signs that make us think of thyroid eye disease. And when we look at, in a number of different ways, and I'll talk about the various studies that we do in these patients, but just a CT of the orbits and both an axial as well as a coronal projection shows the characteristic enlargement of the extraocular muscles that we see in this condition. Remember that although we learn from the textbooks that it's the inferior and medial rectus muscles that are characteristically involved first, the lateral and superior rectus muscles can be involved as well. And there are certainly cases where an isolated involvement of the superior rectus muscle can occur and lead to double vision, so that pattern emerge. Now remember that not all patients with thyroid eye disease present with double vision. Some of them may present with very subtle lateral flare where the outer part of the eyelid is elevated. This patient came in complaining of ptosis of her left upper eyelid, but we can see that she has inferior scleral show on both sides, and she actually has retraction of her right upper eyelid that is causing a compensatory slight drop in the left upper eyelid. Patients like this appearance, right? Because in most of the world of having a more open eye is considered to be more attractive. And so they don't recognize that this is the abnormal eye and this one is more normal. So the patients who present with double vision and have no history of systemic thyroid disease are quite possibly going to have a euthyroid Graves' orbitopathy. And it's important that we keep in mind, as ophthalmologists and neurologists, that the onset of the eye disease may precede systemic hyperthyroid symptoms by a number of months. Anywhere from 12 to 36 months afterward, the patient may ultimately go on to develop systemic hyperthyroidism, but some of them never develop any systemic thyroid dysfunction. The thyroid gland stays completely normal, but they have the classic signs and symptoms of thyroid eye disease. Now, there's been some thought that their initial antibody status, if they have positive antibodies or high titers of antibody, in particular the TSI, the thyroid stimulating immunoglobulin, that makes them more likely to go on to develop systemic hyperthyroidism, but that's not always true. There are two typical antibodies associated with this disease, the thyroid stimulating immunoglobulin, and then also the thyrotropin binding inhibitory immunoglobulin, sometimes referred to as TRAB as well. Now, again, as ophthalmologists, we will see these patients who come in with new double vision or other symptoms. They may also have asymmetric involvement of their eye and orbit. And what I mean by that is in a study that was done where they looked at a group of patients who had systemic hyperthyroidism and a group of patients who did not have systemic hyperthyroidism. This had no hyperthyroidism. This group had hyperthyroidism. So group A, no hyperthyroidism. Group B, hyperthyroidism. Asymmetry, involvement of one orbit more than the other, was much more common in the patients with the euthyroid Graves, normal systemic thyroid function, than in the patients who had a history of systemic Graves' disease. And then if we looked at antibody levels in these different groups, again, hyperthyroid, so the typical Graves' disease versus euthyroid eye disease, they were likely to have a positive TSI, but they were less likely to have a positive TBII compared to the patients who had systemic thyroid disease. So what does that tell us? That tells us that we just need to be suspicious, even if the antibody tests are negative. Now, we do see that the TSI in particular, the levels of it as they go up. So these are quartiles of TSI levels. So these are the patients with the highest TSI levels. These are the patients with the lowest ones. You can see that there's a linear increase in the number of patients who develop these various eye changes. So if we look at strabismus in particular, the ones who have the highest TSI levels are the ones who are most likely to develop strabismus. What should we do if we have a patient with thyroid eye disease as the cause of their double vision? How are we going to manage that acutely and then chronically? The whole topic of thyroid eye disease, of course, I could spend an hour talking about that. I'm not going to today because we have a number of other topics to cover, but I'm happy also to take questions about this at the end. But typically what we recommend is that first determine if they have systemic thyroid dysfunction. Involve the endocrinologist, and if their thyroid gland is out of control, stabilize their systemic status. That can be done with medicine. There has been some research that suggests that surgical thyroidectomy is even more effective, not only in allowing the endocrinologist to get their systemic disease under control, but also to maybe reduce the severity of their eye disease. I think the jury is still a little bit out on that. And then we want to determine the disease activity, meaning, do they have redness, swelling, pain, or is their disease changing? We define this as active thyroid eye disease. And there are a number of agents for medically managing it. Historically, we've used steroids either by mouth or by intravenous infusion weekly, which seems to work better. But more recently, we have advocated the use of some biologic agents, including rituximab or tocilizumab. I know these may be difficult to get in South America, Central America. Teprotumumab is a new drug that was just introduced in the United States, approved at the end of January. It is a monoclonal antibody against the IGF-1 receptor. And again, it's an expensive drug. It may not be practical to be used in other parts of the world, but hopefully it will become an option for all of you to use as well, because it's an exciting drug that may work better than the other things that are available. If the patients have inactive disease, we're going to observe them. They're not going to respond well to any sort of medical management. And then finally, definitive treatment of their diplopia. Work by my colleague Mathura Tamhankar and others has shown that some of these patients tolerate surprisingly large amounts of prism in glasses. So it's reasonable to try that. In the short term, occlusion may be the only thing you can do. And then with strabismus surgery, when the patient's condition is no longer changing, when their deviation is stable, it's important to remember that standard tables may not apply. Different techniques of strabismus surgery and thyroid eye disease have been described by a number of different people over the years. And at this point in time, it's a little beyond our discussion today. So in terms of other mechanical causes of double vision, remember that it's not all thyroid eye disease. This was a young man. He didn't really remember having any trauma, but he did have double vision. And when he looked up, you can see that the right eye doesn't elevate very well. When he looks down, maybe that right eye doesn't even depress quite as well as it should. And he had an orbital floor fracture entrapping his right inferior rectus muscle. There was some degree of swelling within the muscle as well that was causing it not to work as well when he looked down, but he had the typical decrease in motility when looking upward. And so with mechanical diplopia, we always want to look for external signs of orbital disease as well. I didn't point out in him that he had a little bit of relative enophthalmos of that right eye caused by the volume expansion from the fracture. But we're always going to look at the eyelids. Are they swollen? Are they retracted? Are they normal? Are they ptotic? Is the movement of the eyelid normal? Does it follow the eye like it should? Or does it hang up like we often see with thyroid eye disease? What's the strength of the opening and closure of the eyelids? Because that can give us some indication as to the underlying cause of disease. And then we always look at the eyes as well. We want to see if there's any injection chemosis, is there proptosis, enophthalmos, or globe dystopia. Now, what studies should we get in these patients who have mechanical diplopia? I think almost all of them require some kind of imaging study. Ultrasound, if you have a good ultrasonographer in your clinic, they may be able to look behind the globe, look at the extraocular muscles, and look for any infiltrating disease, look for early thyroid eye disease. They may see an orbital lesion that's causing restriction. I feel that CT scan is a much better initial study to get in most of these patients because it's better for looking at orbital lesions, better looking at the bones, and will allow you to identify abnormalities. MRI, when performed correctly, may be helpful as well, but it is not my first study of choice in patients in whom I suspect mechanical diplopia. So let's move on from here to neuromuscular diplopia as the cause of binocular double vision. And if we look at that, what we see is that, I do have a question before I move on. Roberto has asked, how excited am I about teprotumumab? It doesn't, he makes a comment that it doesn't seem to be more effective than steroids or rituximab. What I will say, Roberto, is there seems to be a very rapid onset of action with teprotumumab. Now, full disclosure, I have served as a consultant to the company, but I don't make any money from prescribing the drug. In fact, you could say I'm going to lose money if it's effective because then I won't do as much surgery. But what I think is a little bit different about teprotumumab compared to, say, steroids or even rituximab or tocilizumab in the small amount of data that's available is that it does seem to have a sustained effect on proptosis, a sustained reduction in proptosis. And there is a longer term study, a follow-up study following patients out to 96 weeks that's going on right now to see if that is a durable effect. Because I think one of the problems that I know you and I have seen with these patients with thyroid eye disease is that once we stop the steroids or once we stop the rituximab even, sometimes that disease rebounds and the patients have, a significant number of them have a recurrence and their symptoms come back. So like you, I don't think it's the cure-all. But I do think the data suggests that it will be better, in particular with the reduction of proptosis, which I don't think the data for steroids or rituximab really supported that they were good at doing that. Maybe tocilizumab does, but I think for that reason, I'm a little more excited about it. But we'll see. We'll see how well ultimately it holds up. So, if there are any other questions, I'll move on to neuromuscular junction disease. And so maybe there is one more question here. I'll look and see. And all right, perfect. So with neuromuscular junction disease, if the patient has double vision, they will almost always have some kind of ptosis to go along with it. And that ptosis can be unilateral, bilateral. It's usually not always the same eyelid if it's unilateral, although some patients it's purely the right or the left eye all the time. It can be symmetric or asymmetric. If it's bilateral, a Kogan lid twitch, as I'll show, is often present, and enhancement of the ptosis on manual elevation of the contralateral eyelid frequently happens. And the severity of the ptosis, people always ask, how severe is the ptosis in myasthenia gravis? And it can be unilateral and complete. All three of these patients have myasthenia gravis, confirmed myasthenia gravis. It can be mild. It can look like levator dehiscence ptosis because there's almost a sense of a higher lid crease over here. This gentleman here, again, there's a more poorly defined lid crease on the left side, but he also had myasthenia gravis. In all three of these patients, their ptosis improved once they were started on appropriate medical therapy. How do we diagnose or how do we look for some of these clinical signs that we always talk about, Kogan lid twitch, enhancement of ptosis? What I do is I have the patient look down for 5 to 15 seconds and then look back up rapidly. And there are two kinds of twitches that actually occur. The more common one, as I'll show you in a moment, is that the eyelid elevates, goes up too high, and then comes back down and becomes ptotic again. Sometimes it can show a rapid twitch. So we'll play this video here. And it is not playing, so we'll move on to the next one. And enhancement of ptosis is based on Hering's law of equal innervation. And what you do is manually elevate one eyelid, look for a new or increased ptosis of the contralateral eyelid. And so static photos here demonstrating that this is a patient clearly with bilateral ptosis. And when we raise the one eyelid, the right upper eyelid, manually elevate that, because there's only one central caudal nucleus sending innervation out to the levators. When you take away the stimulus for that activity, the other eyelid comes crashing down. And similarly, if we lift the left upper eyelid, the same thing happens on the right. And so in these instances, we are not going to be too surprised to see that there is this significant enhancement of ptosis. This can occur with ptosis for any reason, but it seems to be more marked in patients who have myasthenia gravis. And it's not clear why that happens, why it's more obvious, but that's simply the way it is. And so if we look here, this is enhancement of ptosis. And so I'm going to raise this patient's right upper eyelid, and you see dynamically how the left eyelid drops, and as soon as I let go of the other eyelid, it comes back up. And it's less obvious when I raise the left upper eyelid, but it's much more obvious when I raise the more ptotic eyelid. That left one comes down significantly, quickly, and then goes back up. When he closes his eyes now and then opens them, you can actually see that there's just almost, you get a sense of a little bit of weakness, and there was a little bit of that Kogan lid twitch. Now, one other thing that I think is important to remember in patients in whom we think myasthenia gravis might be the cause of their double vision. So what are some of the characteristic features we see in patients with myasthenia gravis who have double vision? One of the hallmarks that I always look for is variability of the examination, that I look at the patient and it looks like maybe the right eye is higher than the left. I turn away to make some notes, I look back and now the left eye is higher than the right. Or there's variability to their ptosis, or they start out with a small esotropia with the eyes crossing and then suddenly they have an exotropia. These are all characteristic signs that we see with myasthenia gravis. Now, there can be a combination of findings with patients who have myasthenia gravis as well as thyroid eye disease. This patient was sent to see me with a history of Graves' disease, and she was sent to see me in the office, Graves' disease, new double vision. I said, okay, I'm going to look at this patient. You can see she has the lower eyelid retraction. She has a little bit of ptosis though, not really upper eyelid retraction like we see with thyroid eye disease. And instead of having a typical esotropia, crossed eyes like we would see in thyroid disease, she has a big exotropia. And so as I looked at this patient and as I examined her further, I'm going to show you this video of her eye movements. You can see that she has limitation of eye movements in various directions. And she is not acting like a patient with typical thyroid eye disease. And she has very weak eyes, easily lift her eyelids open despite the fact that she is really trying to squeeze them closed very hard. And this is a patient who developed myasthenia gravis in the context of thyroid eye disease. Now, myasthenia gravis may only occur in 1 to 2% of patients who start out with thyroid eye disease. It's more common for it to happen the other way, where 5, maybe up to 10% of patients in some studies of patients, 5 to 10% of patients with myasthenia gravis can go on to develop autoimmune thyroid disease. So I always keep those two things in mind. And if I think the patient has one disease, but they are showing signs that are more characteristic of the other disease, that's not unusual because the two diseases can go hand in hand. What's the sensitivity and specificity of these various signs and the tests? The Kogan lid twitch that I showed you or described to you has about a 75% sensitivity, but is highly specific for myasthenia gravis. Forced eyelid closure is thought to be very sensitive and specific as well. So if you have the patient try to forcibly close their eyes and you're able to open the eyelid with the finger like I did in that previous video, that is a characteristic sign of myasthenia gravis. The enhancement of ptosis, fatigue with sustained upgaze, they may be less sensitive and specific, although again, they are characteristic of myasthenia gravis. The ICE test, I didn't show you photographs of it because of time considerations. It's been described where you have the patient close their eyes first and do a rest test for 2 minutes. If they open their eyes and the ptosis has improved by 2 millimeters, you don't even need to apply the ICE. But the ICE test is more sensitive in that if you place ICE on the mortotic eyelid for 2 minutes after they've already done the rest and it was negative, and you see a 2 millimeter or more improvement in that ptosis, that's felt to be very diagnostic of myasthenia gravis. The initial study said it was 100% specific. There's nothing in medicine that's 100% specific, but it is quite specific. The sensitivity is reduced if they have complete ptosis. So if you get a negative ICE test, but you have complete ptosis, don't take that as strong evidence that the patient does not have myasthenia gravis. The ICE test for diplopia has been described as well, where you place ICE over both eyes for 5 minutes. Now, I don't like doing that because the patients really don't like doing it, but it's thought to be highly specific, although not very sensitive. And then electromyography may be the most sensitive test, especially single fiber electromyography with an up to a 95% sensitivity and specificity. Now, in whom do I consider neuromuscular diplopia as the cause of the patient's double vision? Well, I consider it in every patient who has new onset diplopia and ptosis. If they have pupillary involvement, I'm going to step away from thinking it's myasthenia gravis, but there are rare cases where the pupil can be involved, and if it is, it's always bilateral. Now, obtaining a complete history is very important because you may have additional information that helps you to make the diagnosis. You look for associated eyelid abnormalities, the ones that we talked about here. I want you to perform the appropriate testing, including antibody testing, looking for the acetylcholine receptor binding, possibly blocking and modulating antibodies. Things like MuSK are less sensitive. I think it's particularly important, especially in older patients, to do a CT of the chest and to look for possible thymoma or even thymic hyperplasia, as surgery for that thymic hyperplasia or thymoma may be curative of the myasthenia gravis. And then for those of us who are not neurologists, I will often refer these patients to a neuromuscular specialist. Now, before I move on, there was a question about when we should perform surgery in a patient who has thyroid orbitopathy. And I think that's important because it applies also, I will be asked, when should you perform, or should you ever perform surgery in a patient with myasthenia gravis who has diplopia? And I think the answer is the same for both, which is actually, for me, when the patient has been stable with their strabismus for at least 6 months and they don't have any signs of disease activity. So with the thyroid eye disease, it would be that they no longer have redness, swelling, congestion, pain, other symptoms to suggest that they're going to have a progressive thyroid eye disease. It can be a little nuanced because you can get orbital congestion from venous stasis, and if they're going to need orbital decompression, that has to be done before the strabismus surgery because it can affect the strabismus. But in general, if the medical activity of their disease is stable, their systemic thyroid status is stable, and their strabismus has not changed for 6 months, I'll be comfortable with operating. Similarly, I have operated on patients who have myasthenia gravis and who do not improve purely from a medical standpoint. If you treat them medically, whether it's with steroids or other agents, and their strabismus is stable, they don't have any systemic weakness, and their disease activity seems to be under control. If they are stable for several months, I typically use 6 to 8 months as a marker, then I am comfortable doing strabismus surgery in those patients. So let's talk about patients who have a neurological cause of their double vision. And I'm going to get rid of this mark that I made on the screen. Fabulous. Okay. So patients who have neurologic causes of their double vision are going to be in a number of different categories. And I'm going to show you just a few examples of patients. This patient had a history of childhood strabismus, but then developed new diplopia. And we can see that she has an adduction weakness of her right eye when she looks to the left, and an abducting nystagmus of the left eye. She has a little bit of weakness of adduction of her left eye as well, but it's more marked with the right eye. Now, this patient here has a more subtle variant of the same thing. You can see that when he looks right and then when he looks straight ahead, he has a slowing of adduction of his right eye. He doesn't really have any significant strabismus. He came to see me because he felt like his eyes weren't working very well together. And in fact, he had a subtle version of the same problem, an intranuclear ophthalmoplegia, that was associated with a known history of multiple sclerosis. This patient presented with new diplopia, and when she looks to her right, it's normal. When she looks to her left, we see a marked deficit of adduction of her right eye only. And you can see that she's a little bit older. She had no history of myasthenia, of multiple sclerosis. And she, in fact, had a small stroke in her brainstem that was the result, that was a cause of her diplopia. This is a gentleman who had experienced a severe bout of uncontrolled hypertension, and he now has a bilateral intranuclear ophthalmoplegia. Interestingly, when he's in primary gaze, he doesn't have that much of an ocular deviation, especially when he's looking at near, because he's able to get convergence to work for him to straighten out his eyes. But when he tries to look right, when he tries to look left, the adducting eye does very little. And this patient also had brainstem ischemia as the cause of his double vision. So this is not a pure cranial nerve palsy, of course. This is a internuclear cause of diplopia in a patient who presents acutely, and neither of these patients had any other neurological symptoms. Even though they both had strokes, they presented purely with internuclear ophthalmoplegia as the presenting symptom. And so in these particular individuals, internuclear ophthalmoplegia, of course, an isolated deficit of adduction of one or both eyes. It's not a partial third nerve palsy. Some of our colleagues will refer us these patients. Partial third nerve palsy almost never involves just an isolated deficit of adduction of one or both eyes. The pupils should be normal, the eyelids should be normal, and sometimes people mistake this for a sixth nerve palsy. So I'm now going to talk about some causes of infranuclear cranial nerve palsies, some management things that I want all of us to keep in mind regardless of where we are in terms of our experience in taking care of these individuals. And so here we have a 61-year-old man who had a sudden onset of headache. It was accompanied by double vision, and then his double vision went away. But why did his double vision go away? His double vision went away because he developed complete ptosis of his right upper eyelid, so he's only looking with his left eye. If we raise his right upper eyelid manually, we see that when he looks left, the right eye is not going to the right at all. And I'm not showing this to you, but it didn't go up or down either. His headache was still present. His visual acuity was normal. And it's difficult to appreciate here, but the pupil was moderately dilated and poorly reactive. So when a patient shows up like this, progressive ptosis, complete ptosis, a total lack of adduction, elevation, depression, and a pupillary enlargement on that side, all of us are going to immediately think of a pupil involving third nerve palsy, and this is no mystery. But this is a patient also who presented with pain and diplopia for 12 hours, and she was not complaining of any ptosis. Her pain was not that bad, but you can see that her right upper eyelid is just a little bit lower than her left upper eyelid. You can also appreciate that she has a small hyperdeviation as evidenced by the difference in the corneal light reflexes between the two sides. So she has a subtle strabismus. Her motility was virtually normal when it was tested. And then it's a bit hard, I think, maybe if you're looking at the computer, when I project this, it's harder to see, but there's a little bit of anisocoria. The right pupil is slightly larger than the left. This patient also had a pupil involving third nerve palsy. It was a partial third nerve palsy, unlike the previous patient in whom it was a complete palsy. And this patient had an aneurysm, compressing her right third nerve as the cause of her new onset pain and diplopia. And so it can be a very subtle presentation. It is not always the dramatic one that I showed before. Now, we used to, we used to have a lot of debate as to whether these patients could be followed. Do they need neuroimaging? I think regardless of where we practice in the world, we should make an effort to get neuroimaging on these patients, just because the consequence of missing an aneurysm is so high, as I will show you. And there's often a debate as to whether an MR angiogram or a CT angiogram is better. And in 2020, it's still true that MRI is better for picking up other causes than aneurysm. It doesn't require contrast, there's no radiation exposure, but it is more expensive and it takes more time. CT has fast acquisition times, it's usually more available, you get more anatomic detail of the blood vessels, but it is a large contrast load, it's a reasonable radiation exposure for the patient, and the radiologist, unless they're very comfortable with interpreting CTA, may have a harder time understanding where an aneurysm or other vascular problem is. Notice I did not mention catheter angiography. That's because now for more than a decade, there has been evidence that CT angiography, and likely MR angiography as well, should be able to detect every clinically important aneurysm that causes a compressive third nerve palsy. So in a series of 137 consecutive patients with an isolated third nerve palsy, they all got CT angiography. This was followed by catheter angiogram only if there was a problem on the CTA, only if it was abnormal. They all had follow-up for over a year on average, and about 20% of the patients had an aneurysm by CTA. 25 of them were treated by coiling, and they were all seen by conventional angiography, and the conventional angiography didn't reveal anything that the CTA didn't show us, and no patient who had a normal CTA went on to experience a problem like subarachnoid hemorrhage. So the conclusion was that CTA should pick up the lesion in any patient who has a third nerve palsy. Now, you notice in that study, only 20% of patients had an aneurysm. And that fits with even an inpatient series of 1,400 patients, where if you take out the trauma patients, you see that tumor, diabetes, and aneurysm, even in inpatients, were still, they made up about half in total of the causes of the third nerve palsy. And 21% of isolated third nerve palsy, so without any other neurological symptoms, were caused by aneurysm, almost the same as in that previous study. So about 1 in 5 patients with a new third nerve palsy will have an aneurysm as the cause. And we know, of course, from the anatomy that this is the third nerve as it passes underneath the posterior cerebral artery. Here's the posterior communicating artery going between it and the internal carotid, and an aneurysm often arises at that PCOM-ICA junction and compresses the medial aspect of the third nerve. This is what it looks like intracranially. You can see this is the internal carotid artery right here. This is the aneurysm dome arising from it, and this is the optic nerve over here. Medially, laterally is the third nerve being compressed up against adjacent structures, and you can understand why this aneurysm is causing third nerve dysfunction. Now, many of you already know why aneurysm rupture is so bad. It's a cause of 5 to 15% of stroke worldwide. And if we take 10 patients here who have an aneurysm, 20%, an aneurysm that ruptures, 20% of them will die before they ever reach medical care because of their subarachnoid hemorrhage. And then 20 to 40% of those who make it to the hospital and are diagnosed with subarachnoid hemorrhage, they die from the acute disease. They die from cerebral vasospasm, they die from stroke, they die from other causes. So we're left with 4 of the 10 patients that we started with already in the acute phase. 50% of survivors have severe disability, so we lose 2 more. They may require shunt, they may have persistent anxiety and depression, so really only 2 out of those 10 patients who started out with aneurysm will leave the hospital in good condition. 80% of them will either be dead or have a very severe effect on their quality of life. In contrast, if you treat unruptured aneurysms, and especially now that endovascular treatment is becoming more common, it's less and less common for patients to need surgery for this. Previously, untreatable aneurysms are being treated. 85% of patients who get their aneurysm treated before it ruptured will have what's called a modified Rankin score, so a measure of neurological function or dysfunction that's essentially normal or only mildly impaired, a much better outcome. So how do we distinguish an aneurysmal third nerve palsy from, say, a diabetic or other less urgent third nerve palsies? Pain is not useful. We still talk about the rule of the pupil, where pupillomotor fibers are located on the inframedial surface of the nerve. The aneurysm grows from the medial side as shown here, so it compresses those pupil fibers first before it starts to compress the motor fibers of the nerve, and ideally the pupil becomes abnormal before there's any ptosis or diplopia. An aneurysm large enough to cause pupillary changes is large enough to need treatment. And then we know in patients who have ischemic third nerve palsy, like from diabetes, it affects the center of the nerve, it affects the motor function, but it spares the periphery of the nerve. So ideally, ischemia won't affect the pupil, compression will affect the pupil, and we would like to be able to say abnormal pupil aneurysm, normal pupil ischemic, but of course that doesn't apply, right? That isn't correct, because the problems with that rule are that it applies only to complete motor palsy with completely normal pupils, where there is absolutely no pupillary involvement. It doesn't get us into incomplete ptosis. If you have preserved adduction, elevation, depression, any anisocoria, then we can't use the rule of the pupil because it only applies to complete motor palsies and even relatively small aneurysms. This is CT angiography that's broken down here with a reconstruction. You can see a small aneurysm arising from the internal carotid artery in these cases caused a compressive third nerve palsy in a patient who presented with new ptosis and diplopia. And so, are there times where you don't have to get imaging? You know, if you had a partial third nerve palsy without pupil involvement, if you are in a place where it's just impossible to get imaging, we still would try to do daily examination of pupil changes and really have a low threshold to get them for a CT and CTA. And in an example of the exception proving the rule, there's only one case in the literature of a complete third nerve palsy with a normal pupil. This was from Neil Miller many years ago, where this patient presented, you can see, with complete right upper eyelid ptosis. Her eye is deviated outwards, but her pupils are completely equal. She does not have anisocoria. She has no adduction, elevation, or depression of this eye, so you would think that she has a complete pupil-sparing third nerve palsy, which she does. And she had a huge aneurysm as the cause, but it was a basilar tip aneurysm. And so it came over the top of the nerve and compressed it from above, so it spared those pupillomotor fibers because they were on the wrong side of the nerve. So a rare case that proves the rule about aneurysm being important. Now, the last thing I want to mention about third nerve palsy are some of the findings that occur later. This was a 38-year-old man who presented with double vision for 2 years. It was worse at distance. He had esotropia, limited abduction of both eyes. He had enlarged extraocular muscles. And you can see that he underwent strabismus surgery and his eyes were then straight. But subsequently, he came in complaining of new diplopia. And with this new diplopia, he now had a deficit of adduction of his right eye. He had a deficit of abduction as well. He had a problem with depression, but he also had some eyelid changes that occurred. And so this was sent to me as a third nerve palsy, but it's clearly not a third nerve palsy. There are multiple cranial nerves involved, and he has aberrant regeneration on this side because when he looks down, his eyelid goes up. and he was found to have a cavernous sinus tumor as the cause of his double vision. Similarly, or in a different instance, this is a patient who developed a traumatic third nerve palsy. She was thrown from a horse, she hit her head, she had intraparenchymal hemorrhage in the area of her right third nerve origin. And so she has a dilated pupil on the right. She abducts well, but she cannot adduct. She does not elevate. She does not depress. And she has complete ptosis. So a complete third nerve palsy from trauma. Now, she went on to improve significantly. She now has more adduction, not good elevation, but some depression. But you can see that same sign of aberrant regeneration, the eyelid hanging up. And on a video, it's very obvious here, where when she looks up, the eye doesn't go up well, but when she looks to the left, the eye is adducting. When she looks to the right, the eye abducts. And now when she looks down, she has aberrant regeneration with the right upper eyelid staying up and maybe even going up a little higher as she looks down. And so I mentioned this here because ischemic third nerve palsy almost never causes. In fact, I'm not aware of any case of a pure ischemic third nerve palsy leading to aberrant regeneration as is seen here. So if we ever see a patient who has aberrant regeneration and a third nerve palsy, we should not think that it is from ischemia. So aneurysm compression is a less common cause of third nerve palsy, but probably the most important one that we want to remember and not miss. Treatment of aneurysms before rupture results in superior outcomes. We want to consider neuroimaging in all third nerve palsy patients, and catheter angiography is not necessary except for treatment. Now, I'll finish by talking about a couple of other cranial nerve palsies, right? Fourth and sixth nerve palsies, the ones that are left, and just maybe point out a few things that I think we've learned over the last several years that may be helpful in the diagnosis and management of these patients. So a typical patient, a patient in his late 30s who has had intermittent diplopia for several years. It's worse when he's tired, and it's been happening more frequently. He has a history of mild multiple head trauma. He was a college football player and got tackled many times. He also, when he was a child, he lived out in the countryside and he would climb trees and fall out of them and do the things that boys often do. And he was otherwise healthy. He had normal visual acuity, he had no RAPD, his ductions were full, and he had no trigeminal or facial dysfunction at that time. So before I move on, I have a quick question here from Tammy. I'm going to read. The majority of our patients come when the aneurysm is ruptured. When the aneurysm is clipped, the recovery of the third is rapidly, but not when the aneurysm is embolized. And that may be because of mass experience or mass effect of the coils. And that's a great point, Tammy, about those patients. Clipping does immediately decompress the aneurysm, and there are reports in the literature as well as experience all of us have where coiling doesn't reduce the mass in the same way, but coiling should cause a longer term reduction in the mass. And I have seen improvement in aneurysmal third nerve palsy after coiling when the coils are not overpacked. So I think it's important that the neuroradiologist, the interventional neuroradiologist, keep in mind that you don't want to overfill with coils. And I think that is easier to do now that they have stents that they can put into the internal carotid artery to allow them not to have to put so many coils into the aneurysm dome so that you don't get that mass effect that is continuing to press on the third nerve. Ideally, again, over time, when you coil an aneurysm, that there's a coil compaction that occurs. Now, it can take several months, and the patient may not recover as quickly as with the surgical clipping. So I think there is still a role for surgical clipping in some patients, but more and more these days with the interventional tools that are available, and one option may be a flow diverting stent in certain patients, because then there's no coil that goes into the aneurysm dome. The flow diverting stent allows the aneurysm to thrombose and then to collapse on itself so that you don't get that mass effect. So I think a combination of those things, more modern treatment as well as the flow diversion, has helped those patients with third nerve palsy to get better after aneurysm treatment, even if they don't have surgery. So going back to the patient who we were describing here, he has intermittent double vision, he has full ductions of each eye, but we can see that he has a right hypertropia that worsens on left gaze. It worsens with right head tilt. I don't have a photograph of this patient, but this is the characteristic pattern, of course, that we see in patients with fourth nerve palsy. Is there a differential diagnosis in a patient like this? Are we going to consider things like thyroid eye disease, myasthenia gravis? He has normal ductions. He doesn't have any ptosis. He doesn't have any variability to his symptoms. And to me, one of the biggest keys is that this is an intermittent right hypertropia of 12 prism diopters. He has increased vertical fusional amplitude, or at least this implies increased vertical fusional amplitude, and suggests that this is a long-standing problem, and in particular, a fourth nerve palsy. Now, one feature that doesn't quite fit, which has been described in the literature, is that these patients tend, unlike acute fourth nerve palsies, where their strabismus is worse when they look down, patients who have had this condition for a long time, often they don't have a worsening when they look down, and they may have a worsening when they look up. And that may be a sign that can differentiate an acquired fourth nerve palsy. So acquired fourth nerve palsy, often worse when they look down, versus a long-standing or more congenital even fourth nerve palsy where that strabismus is worse when they look up. Not 100% by any means, but one clue that you can use. Acquired recent onset, worse looking down, long-standing, maybe worse looking up. So how are we going to work up these patients? How are we going to manage them? Well, looking back at old photos is often helpful. This is a different patient who came in with the similar complaint of intermittent double vision. You say to him, straighten out your head. And he says, my head is straight. It's always been like this. And he comes with his wife who says, oh, his head has been tilted like that forever. And in fact, he shows you an older photo from 10 years prior, and his head was tilted in a similar way. So very instructive. Now everyone has Facebook pictures or their pictures on their phone, and they can just scroll back through those pictures and show you and say, oh, look, my head was tilted to the right like that for years, and I just never noticed it, or no one pointed it out to me. So with the fourth nerve palsy, we look maybe for a little subtle inferior scleral show only on the affected side. We see the difference in the light reflex pointing to the left hypertropia in this person with a left fourth nerve palsy. And when they look down and to the right, we see that there's a deficit of superior oblique function. And here we see relative inferior oblique overaction being pointed to by this arrow when the patient is looking up and to the right, and we don't see the same thing occurring with the unaffected right eye. So with fourth nerve palsies, maybe 20 to 30% of them are previously undiagnosed congenital, 20 to 40% traumatic. They may be bilateral when they're traumatic, and then ischemic microvascular fourth nerve palsy does occur, although it is a less commonly diagnosed condition. Aneurysm rarely, tumor rarely causes it, and sometimes we just don't make the diagnosis. One entity which has been described more recently is fourth nerve schwannoma, and as MRI has become better and better, we are better at picking up these small enhancing lesions involving the fourth cranial nerve, and these may be causes of long-standing fourth nerve palsy. This was a patient who came to me with bilateral is a larger schwannoma on the right side than on the left side, and she had an asymmetric fourth nerve palsy as well. And so I'm going to leave fourth nerve palsy and finish with just talking briefly about sixth nerve palsy and various investigations we might do in patients who have an isolated deficit of abduction of one eye. This was a 68-year-old woman who came to see us with well-controlled hypertension, no diabetes. She was a non-smoker. She was a retired office worker. She had no recent foreign travel. None of us have any recent foreign travel now. We noticed that she had sudden onset diplopia 6 days ago. With no pain, no trauma, she was systemically well, she had no ptosis, her exam didn't change over the course of my testing, no fatigability, and her visual acuity was normal, she had equal pupils, but you can see she has a deficit of abduction of her right eye with an esotropia worse in right gaze. She really only had diplopia at distance, not at near. She could fuse at near with an intermittent esotropia. Her fundus exam was normal. Her blood pressure was normal. She had no weight loss, jaw claudication, other symptoms to suggest giant cell arteritis. I always keep in mind giant cell arteritis is a potential cause of an ischemic cranial nerve palsy or new onset diplopia in patients over the age of 60, because there can be ischemia either of the nerve or the extraocular muscle that can cause strabismus. So the question that always arises, should we get neuroimaging in this patient? Does this patient need imaging? And in a study that we published about 7 years ago now, looking at isolated third, fourth, and sixth cranial nerve palsies in a prospective manner, over 100 patients were enrolled. And what we did is every one of them got neuroimaging done. And what we found was that 16.5% of these patients who came in with an isolated mononeuropathy, single nerve involved, 16.5% of them had some other cause, not microvascular ischemia, something that was picked up on the MRI that pointed to a different etiology. And so I encourage you to consider, again, if you practice in a place where the resources allow you to get neuroimaging on these patients who have presumed microvascular ischemia, a presumed problem secondary to their hypertension or diabetes, it is not unreasonable to get neuroimaging to look for an alternative cause, because 16.5% of patients will have some other reason. And those reasons were as widespread as subacute pituitary apoplexy, meningiomas, and aneurysms. So you will pick up clinically relevant lesions. Now, in most patients, would it matter if you waited 6 weeks, waited for them to improve, and then got the imaging when they didn't get better? No, probably not. A meningioma is not going to kill any patient. But at least in the United States, if my patient comes to me and I say, oh, I think this is just your diabetes, or I think this is your hypertension, and they don't get better, and they come back and see me 6 weeks later, and I order an MRI, and now it shows a tumor there, that patient is going to think that I'm a bad doctor. They're going to maybe think, I don't know what I'm talking about. And is that the greatest reason for getting imaging? Maybe not, but this is the world we practice in. And so there are a lot of different reasons to go ahead and get imaging. Now, you don't always need imaging, of course, to know where the problem is, right? This patient has ptosis in addition to a sixth nerve palsy with esotropia, and they have a little bit of meiosis. So they have a Horner's syndrome on the left side, along with the sixth nerve palsy. And we know that that localizes very nicely for us to the cavernous sinus. And indeed, he had a cavernous sinus meningioma. This is different because this is not an isolated sixth nerve palsy. This has other signs going along with it. And I don't think anyone who recognized that a patient had a sixth and a Horner's would not get imaging right away. You would not wait for 6 weeks to see if this patient got better. So in the course of doing all of this, of course, fourth nerve palsies are not the only cause of vertical diplopia. Sixth nerve palsies are not the only cause of horizontal diplopia. We looked at neuromuscular junction problems, mechanical problems that can mimic fourth and sixth nerve palsies, and restrictive and paretic strabismus may look very similar. We have to keep all of these entities in mind every time an adult patient walks in with new onset diplopia. We want to look for eyelid and orbital changes to guide our differential diagnosis. I think it's reasonable to consider neuroimaging in all patients with new onset double vision. If you think it's mechanical, getting a CT of the orbits. If you think it may be cranial nerve, getting an MRI of the orbits and brain, looking at the cavernous sinus as well as the path of the cranial nerves. And of course, we're never going to forget monocular diplopia when we first see that patient, so that we don't go and do all of this testing for no reason, when in fact the patient's double vision is coming from something simple like dryness of their eyes. So I'm going to stop there, and I'd be happy to take any more questions since we're at our 1 hour. So thank you all for your attention and for attending today, and Emily for extending the invitation for me to speak to everyone. Thank you.
Gracias, Prem. Thank you, Prem, for accept the invitation and also for the great talk. Tengo una pregunta. Aquí tienes, creo que unas preguntas. Do you want to read the question?
Yeah, no, I think I answered the questions
Yes.
that were here. Did we get any other from Facebook that people have asked, or?
No, I have a question. What is the best test for you in order to make a difference between skew deviation and Fortner? Do you use the upright supine position, or what do you prefer? I mean,
Sure. So I do like the upright supine test. So what Emily is talking about is that in many cases of fourth nerve palsy, when you measure when the patient is upright and then you place them supine, there will not be any difference between those two positions. But because skew deviation has to do with this vestibular input as well, that when you measure the patient's vertical deviation and then you put them supine, that it may decrease by 50% or more. So I think that when it is positive, it's very helpful. In other words, when there is that change, it's very helpful. But I have seen skew deviation patients where there's been no change between upright and supine. So if there's no change, then I think it's not helpful. But if there is a change, then I think it is helpful.
Okay, thank you. Sometimes my resident asks me, what is the best treatment to begin with the myasthenia, ocular myasthenia?
So I do like to start the patients on steroids. So I will treat ocular myasthenia gravis myself, even though I'm an ophthalmologist. And that's just because I've done it for many years. So I will start prednisone to see if they get better. And if they get better on prednisone, and I will go up to about 40, 50 milligrams per day. If they get better with that, then I transition them very quickly to some other agent like azathioprine, like Cellcept, to try to get them off the prednisone. And then I end up treating them for several months or even a few years. But so what's the first therapy I use? Steroid, definitely. Because, and then if steroid works, then I try to get them on a steroid sparing agent.
Okay.
So,
You have many.
Yeah, and I see some questions here. So we have, in fourth nerve palsy, whatever the cause, where I draw the line between surgery or prisms in terms of prism diopters. I tend to not like to give patients more than about 6 of the vertical prism, because I find that they start having trouble, especially if they have any incompetence, that when they look down, they need different prism. When they look straight ahead, they need different prism. And because in many cases of the fourth nerve palsy, surgically, just a single muscle, an inferior oblique recession, or even myectomy can, really take care of their double vision. I actually have a low threshold for operating on those patients.
Mm-hmm. You have another question in there.
Yeah, I see that. It's the best surgical technique to correct strabismus in patients with thyroid strabismus. So that's a fabulous question, because there are entire symposia and meetings that talk about what are the best techniques to use. So I will say some things that I always do. I almost always use adjustable sutures. I think these patients are more likely to benefit from having adjustable suture surgery. I am very careful, though, about adjustable suture surgery on the inferior rectus, because the inferior rectus seems to be a little more likely to slip. I will often operate on both inferior rectus muscles, even on the higher eye, because if you don't operate on both, you can easily end up with a postoperative overcorrection, particularly when the patient looks down. So those are just a few of the things I do. I will intraoperatively try to base the amount of surgery based on how tight the muscle feels with doing forced ductions. I think it's extremely important to do forced ductions as well, and to maybe modify your surgery, do a little bit less surgery, in other words, a smaller recession if the muscle is extremely tight, because I think you're going to get more effect for each millimeter of recession you do.
Okay. Mm-hmm. You have a comment for Roberto?
Yeah, I saw a comment from Roberto based on what I said about fourth nerve palsy. He tends to go up to 8 prism diopters of prism. I think they're, I think we're thinking in very similar ways.
Well, you have too many congratulations. Excellent talk, great presentation. Thank you so much.
All right. Well, thank you very much. Thank you all for attending. And thank you, Emily. For
to have you here. Thank you so much.
Great, Prem.
All right. Thank you.
Very much enjoy your talk.
Thank you, Roberto. Appreciate it.
Thanks, Prem. Great job.
Thank you.
Thanks a lot.
Thanks, Greg.
Muchas gracias a todos. La otra semana los espero. Y yo también quiero darle las gracias a Cristina, que me ha ayudado mucho con esta proyección. No es su trabajo, ella es algo espontáneo que ella me está ayudando y por eso la que está detrás de las cámaras, muchísimas gracias también. Gracias a todos, los veo la otra semana. Gracias, Cristina. Cristina es la que nos ha hecho las proyecciones, las comunicaciones.
Oh, bueno.
Espontáneamente me ha ayudado, no es su trabajo y lo ha hecho muy bien y hace las grabaciones y todo. Gracias, muchísimas gracias a todos. Gracias, Prem.
No te olvides de pasar
Thanks,
la
Prem.
semana
Thank you
que
very much.
Gracias, hasta luego.
Ok, hasta luego. Gracias.
Ciao, Emily.